So my colleagues of very high standing in the Singapore arena of pancreatic cancer, and today we're privileged to have this group to be able to share with us on exactly those topics, to be able to enlighten us on all those aspects, starting with things we can do about our diet and lifestyle, moving on to things about rehabilitation in terms of preparing ourselves should we need surgery, what to do if somebody says, hey, there's something on your pancreas, what do we do now? And in the unfortunate event that you do need to have surgery, how to do that surgery safely with good outcomes. And these are the 4 topics that will be shared today. Just a little bit about the kind of format of the afternoon so you know what to expect. 4 very eminent speakers are going to be talking to you. And please, either on your pencils and papers, jot down the questions, because it's easy to forget those questions once you go through those 4 talks. Or on your phone, just type it in, because the Q&A will be together with all me and my colleagues on the stage to take the questions. But perhaps one of the most deeply reflective part might come after that, where 2 of our cancer survivors, pancreas cancer survivors, have kindly come together to be able to share with us their journey and where they're at so far, and that's a moderated session at the end. So I hope it's a useful afternoon to all of you. So it brings me great pleasure to introduce our first speaker. Our first speaker is the Executive Director of the National Cancer Institute of Singapore. She's Adjunct Associate Professor Chi Cheng Yen, and she's here to talk to us about lifestyle modifications associated with pancreas disease.
So I got a topic about food. I think this is, I'm a medical oncologist. So I give chemotherapy, so I work closely with the surgeons. And the number one question I always get after I talk about chemotherapy is, what can I eat? So today I'm going to tell you a little bit about how can what I eat prevent or improve my treatment in pancreatic cancer. So a little bit of background. Where's the pancreas? I think in Mandarin it's called the yin zhang. It's an organ that sits close to the small bowel at a very important junction, lots of blood vessels going through, and there are 3 parts, the head, the body, and then the tail of the pancreas. Now, I think Professor Glenn shared with you earlier, the incidence is rising. Here's some statistics from Singapore. So from 2017 to 2021, if you look at men and women, pancreatic cancer is up there. It's actually one of our top 10 cancers affecting men and women. But the sad thing is, in terms of mortality, it's actually the top 5. Yeah. So what risk factors? Unfortunately, with cancer, right, the older you get, age is a risk factor. And we can't change that. But there are other risk factors that you can, change. Another thing you can't change is your family history. So there are certain genetic syndromes that can increase one's risk of getting pancreatic cancer, like the BRCA mutation, associated with breast cancer. Smoking, this you can change. So we know from data that if you're a smoker, you're twice as likely to develop pancreatic cancer. So quit smoking. If you are smoking, the risk does go down when you stop smoking. Heavy alcohol use, another risk factor. Again, you can, take charge and change that. Diabetes, obesity. So data has shown that if you are obese, actually the risk of developing pancreatic cancer is 20% higher than someone who is not obese. And then pancreatitis. Pancreatitis is a condition where the pancreas becomes inflamed. And if you keep getting pancreatitis, that predisposes you to pancreatic cancer as well. And we know that heavy alcohol use and obesity actually increases one's risk of pancreatitis. So, very simple things. Quit smoking, cut down on your alcohol, get to a healthy weight. These are the things that you can do to change to adjust your risk of developing pancreatic cancer. So prevention strategies, maintaining your weight, we have to move more. I think in society now, it's very easy not to move because we have the mobile devices right in front of us. So please move and, of course, eat well. And we'll come to that in a bit. So in terms of prevention, what can you eat to prevent pancreatic cancer? Not a lot of new things. I think this is something that we are in denial about. Lots of, whole grains, fruits, vegetables. We learned this from school. Our dietitians tell our patients, our family preaches to us, but that's where the data is. So healthy diet, vegetables, fruits, whole grains. Not great things to have, our bubble teas, sweetened drinks, McDonald's, fast food, not a good idea, maybe once in a while, but fast food isn't great. Meat, red meat, processed red meat, again, less of that. And of course, alcohol as well. So everything in moderation. And, if you are undergoing treatment for pancreatic cancer, whether it's surgery or chemotherapy or radiation therapy, what can you do in terms of, adopting your diet? So, here at NCIS, all our patients, newly diagnosed, they go through a tumor board. A tumor board is a group of specialists that focuses on pancreatic cancer work, from surgeons to radiologists to radiation doctors, medical oncologists like myself. We have our pathologists, the radiologists who read your scans. We sit down once a week for about an hour or two to review all our cases. And then we decide what's the next best course of treatment. Should you have surgery? Should you have chemotherapy? Should you have radiation? And then we also see, are there new things that we can do? Can we use technology, sending the cancer sample, sending blood tests overseas to see what we can have targeted therapies or newer forms of cancer treatment as another form, or a clinical trial, an opportunity to try something new that you may not get as standard of care. So this is what we always do, every week across all different cancer types at NCIS. But, besides the treatment part, how can you optimize your nutrition during and also after treatment? Because regardless of any treatment type, pancreatic cancer can take a toll on the body, and the person's ability to maintain a healthy diet and nutrition, it's tough. I'm not going to, sugarcoat this. So a few tips. So I was kind of reading the literature. I thought what might resonate, and also thinking what are the common questions my patients ask me. How to maintain a healthy weight, right? It's easy to preach, maintain a healthy weight, keep healthy, maintain healthy. But I think sometimes we forget that going through major surgery for cancer, going through chemotherapy, it is normal to lose some weight. Okay, so we accept that because it's tough. And also excessive weight loss, so you can lose some weight, but losing too much weight is actually, that's the one that we don't want. Because excessive weight loss and poor nutrition can cause a decrease in the body's ability to fight infection and treatment. So I have patients that come in, right? They are told by a lot of people, and Google, the very famous source of truth, that they should avoid every single thing under the sun. And then I tell them, actually, I need you to eat because your body needs to recover. The building blocks need to build back, all the parts, such as your blood, because you're going to be undergoing chemotherapy. And then they look at me with like, you're ridiculous. How can I eat everything? Are you sure I can eat prawns? Are you sure I can eat durian? I said, yes, you can. And they eat. And the thing is, when they don't eat, that's a problem. When you are really malnourished, it's a struggle to get through treatment. Another tip, keep well hydrated. Simple things, your 8 glasses of water that we keep being told that we have to drink. It is important. But of course, sometimes after pancreatic cancer surgery, you might feel full easily. So some advice that our dietitians give our patients is to avoid, drink the fluids maybe an hour before meal. Let the fluids pass before you have your meal so that you can have a proper meal. And of course, choose beverages that contains calories and nutrients. So for those who are on your milkshakes, your milk supplements, that's your liquid. Okay, it's not in addition. It's part of that 8 ounces times 8 a day. Avoid excess caffeine and alcohol. So you can have your cup of coffee, okay, but avoid excess. So everything in moderation. Eat small, frequent meals. I think because of the nature of surgery, because of the nature of the disease, the pancreas is associated with digestion. It's tough to finish a big bowl of noodle or your nasi lemak. I can tell you that. So we tell patients, eat small, frequent meals so that you can tolerate, you can digest. And also sometimes with chemotherapy, there's a little bit of nausea and there's a little bit of change in appetite and taste. So you might not want a very big meal in front of you and then feel disappointed that you can't finish it. Tip number 4, enrich your diet with high protein and low fat foods. Why? Because protein-rich foods help your body to repair damaged cells. And it helps the immune system in recovering from your chemotherapy, from radiation therapy, from surgery. We need that building blocks. Lean protein is encouraged and should be included with each meal and snack. This is my favorite. Reduce gas-forming foods. Doesn't mean don't eat. Maybe eat less or less frequent. Pancreatic cancer patients with or without surgery struggle from abdominal gas, partly due to the digestion. When food is not digested properly, gas builds up. So what can you do? Because gas is uncomfortable. There's a bit more bloating, burping, passing of gas, and it may interfere with your daily activity. Being bloated all the time is not nice. So, and the other thing, how it's related to high-fat foods actually slow down your motility. And in patients who've had surgery from pancreatic cancer, digestion of high-fat foods might be quite tough. So that's why the advice of going on low-fat foods and also reducing intake of gas-forming foods. This is our favorite handout. The handout that I have to give the most to all my patients is this handout, how to manage abdominal gas. Simple things. People always say, I must eat a ton of broccoli because they told me it's antioxidant, so I have to eat a lot. But unfortunately, it causes gas. So you can have your broccoli, but don't eat it every day. Eat a little bit or less frequent. You can still have your broccoli, okay? Okay, tip number 6, limit sweets and added sugar. Again, you can have sweet. Please do not avoid all sugar because you might faint. But just limit the additional, temptation of having a very big slice of cake, everything in moderation, because you can have trouble digesting foods. And a lot of pancreatic patients, they have diabetes as well. So if your sugars run high because of diabetes, I don't think you feel very well as well. Tip 7, during chemotherapy, because the immune system is down, we tell patients to avoid uncooked or partially cooked food because of the risk of food poisoning. Just common sense. I've had patients, they had their onsen egg one day, and then the next day they landed up with really bad food poisoning, and it was really terrible. Okay, so you can have eggs, make sure they're fully cooked. And the last tip is, avoid fruits that can interfere with your medicines that you take. This is not particularly just to chemotherapy. Actually, when you're taking blood pressure pills, certain cholesterol pills, you should be avoiding these 4 fruits. So starfruit, pomelo, pomegranate, and also grapefruit, because it interferes with how your drug is what we call metabolized, is cleared from your body. So there is some drug-drug interaction. So we tell patients to avoid this. I think this is not very commonly eaten, but I know starfruit is quite, people like it. Pomelo, Chinese New Year is always a problem with the yisang. So we tell patients to avoid these fruits. So in conclusion, to prevent cancer and while having cancer treatment, it is important to maintain a healthy weight. Please move, stay active, just move, and move. And then you can still eat well, but most importantly, eat in moderation. Thank you very much.
Thank you, Professor Chi. I hope you enjoyed that talk, and we'll move along now. I'd like to just inform you that we're here on behalf of NCIS, but how it works is NCIS works across 2 sites and soon to be 3 sites. So while some of us are primarily surgeons and doctors in NUH, there's a whole team of doctors and oncologists also in Ng Teng Fong Hospital. So once a week, as Prof. Chi just alluded to, we come together as a group to discuss all the cancer patients, make sure that we're consistent and following the best evidence of care. So our next speaker is the head of liver and pancreatic surgery in Ng Teng Fong Hospital. Dr. Yong Xian is going to come and talk to us about, so I have something in my pancreas, what do I do now?
Hello everybody, I'm Yong Xian. I'm from Ng Teng Fong. And the topic that I'll be discussing is I have something in my pancreas, what do I do now? So I'm just going to touch on some basic facts of the pancreas. The pancreas is an organ within the abdomen. It secretes insulin for glucose control, and it also helps in fat digestion. So pancreatic lesions can occur within the pancreas. If it is a solid lesion, one would be more concerned about cancer, whereas if it's a fluid-filled or cystic lesion, we would think it's more likely to be non-cancer or precancerous in nature. So this is the typical patient journey. So as the patient tends to have some symptoms. They might get jaundice, loss of weight, loss of appetite. And then they'll see the general practitioner. Some initial investigations might be done, including blood tests, a liver function test, or an ultrasound test. And then this begs the question, I have something in my pancreas, what now? We divide the management process into 3 stages. The first stage would be a confirmation of diagnosis. If there's a cancer diagnosis, we need to assess the extent of the disease, and stage 3 would be treatment. So to confirm the diagnosis, the investigations are broadly divided into non-invasive investigations or invasive investigations. The non-invasive investigations would be the CT pancreas or the MRI pancreas, whereas the invasive investigations would be the EUS or the ERCP. I'll go into more details. So this is a typical CT pancreas machine. The patient lies on a bed and has to be wheeled through this donut-shaped looking machine. It is non-invasive in nature. Basically, it uses multiple X-rays to create an image for the surgeon or the physician to look at. Compared to the other modalities, it's relatively cheaper and more accessible. So you'll get an image as seen in the bottom right-hand corner. You can see the liver, you can see the pancreas, and you can see the spleen in quite great detail. The next common tool that we use is the MRI pancreas. It's non-invasive in nature. You use magnetic waves to get the images. It takes about 45 minutes to acquire. And then you get the images as seen on the right. So if you see these images, you'll know me inside out because these are actually my own images. So you see my liver. I have a small liver cyst, my pancreas, and my stomach. So it takes about 45 minutes to acquire. And it's probably not suitable for patients who are claustrophobic because it is really noisy and you'll be there for 45 minutes. But it does provide better characterization of the biliary and ductal system. The next invasive investigation would be the endoscopic ultrasound. Why is it invasive? It's because we have to introduce a scope all the way down to the pancreas. There's an ultrasound probe at the end of this scope. And basically, you get an image of the pancreatic lesion. The benefit is that you do get tissue samples. This could be non-cancer tissue samples or pre-cancer tissue samples. But because of the invasive nature, there is a small risk of complications, about 2.5%. The other investigation that's commonly done is the ERCP. It is a scope that's used together with X-ray technology. It's often performed in the presence of deep jaundice or when there's infection in the biliary system. And this allows a stent to be introduced to relieve the jaundice so that the patient can either receive treatment or go for surgery. During the insertion of a stent, we also can get tissue samples. This typically takes about 30 to 45 minutes. And also because of the invasive nature, there's also a small risk of complications. So we are coming to the end of stage 1, whereby we'll get an idea of what lesion we are dealing with. If it is a solid lesion, we tend to be more concerned about cancer. So the most common cancer is the adenocarcinoma, which happens in 80% of the patients, followed by the neuroendocrine tumor, the pancreatic lymphoma, and the pancreatic metastasis. If it is a fluid-filled lesion, this lesion tends to be non-cancerous or precancerous. The serous lesions, whereby the fluid is very thin, non-viscous, they tend to be the non-cancer lesions. Whereas if you have a mucoid lesion with thick viscous fluid, then this tends to be the precancerous lesions. So after having a confirmation of the diagnosis, and if there is unfortunately a cancer diagnosis, we move on to stage 2 of the management, and that would be to assess the extent of the disease. And how this is done is we normally do a CT scan that covers the lungs and abdominal area to look for distant disease. Common sites where pancreatic cancer spreads will include the liver, the abdominal lining, and the lungs. If disease is localized, we can consider surgery. However, if disease is widespread, then we might need to give chemotherapy. So I'll just give some real-life examples and show the patient journey so that everyone can better understand how it happens. So this is Mr. L. As you can see, he has a deep jaundice. He has a past medical history of diabetes, had some hypertension. He presented with 3-week history of painless obstructive jaundice. He has some occasional epigastric discomfort, some loss of weight, loss of appetite. We did some initial blood investigations. The bilirubin was high, 251. So we went on to stage 1 to confirm the diagnosis. So at stage 1, we did a CT scan. It showed a dilated bile duct and a lesion within the pancreas, as seen at this red arrow area. Okay. So what we subsequently did was we relieved the jaundice by stent insertion, and at the same time we got some tissue sampling, and that proved that unfortunately it was cancer. So stage 2 showed no disease, no distant disease, and then we went ahead to do a laparoscopic pancreaticoduodenectomy. These are his scars on the right side. He stayed in hospital for 5 days. The histology actually showed cancer, but thankfully we managed to remove it entirely. And he has disease-free survival for the last 18 months. So the next patient is Madam H. She's a 49-year-old female, totally asymptomatic. She works as an executive, and she had a CT scan done for her health screening, and the tumor markers were just mildly elevated. Because of the CT scan, we had to do an MRI pancreas, and this showed a precancerous fluid-filled lesion. These are the MRI images. So you can see there's a fluid-filled lesion ahead of the pancreas, as seen on this red arrow. There's a dilated pancreatic duct all the way to the tail of the pancreas. Thankfully, she did not have any distant disease, and we went ahead to stage 3 and did a laparoscopic total pancreatectomy. So for her histology showed that it was pre-cancer. This was a fluid-filled lesion. She stayed in hospital for about 4 days. So I'm just going to summarize. So in summary, when a pancreatic lesion is suspected, it's often the beginning of the management process. And the management process would involve 3 stages. The first stage would be the confirmation of the diagnosis. Second stage, you would have to assess the extent of the disease. And a third stage would be the treatment phase. Thank you, everybody.
Thanks, Dr. Yong Xian. And we're starting to get a flavor a little bit of what the tests are required leading up to surgery. I think it's important to emphasize also that surgery on the pancreas is complicated surgery. We'll be hearing a talk about that from Professor Kao in a moment. Dr. Yong Xian has shared with us some excellent results in those 2 patients. But in order to achieve such results, it's not just in the hands of the surgeon. It's actually quite a lot in the hands of the patients that come up to have that surgery, because there's quite a lot of optimization that goes up to actually doing that. Our next speaker is Dr. Pang Ning Chi. Just on the side, as we've got a little bit ahead of time, it takes a long time to train a surgeon, as you can imagine. A lot of us spend many, many years of our lives training to be a surgeon. But Dr. Pang, once he qualified, he was still bored, and he decided that he's going to do a PhD on top of being a surgeon. So he's in the final year of his PhD, and his PhD is actually to do with rehabilitation prior to surgery and optimizing patients for surgery. So I can't think of a better person to speak about this, and so I introduce Dr. Pang Ning Chi, who's a consultant in the Division of Hepatobiliary Surgery at NUH.
So my name is Ning Chi, and I'm one of the consultants in NUH, and I work in the surgery department with Professor Bonnie and Professor Kao. In fact, both of them are closely involved in my PhD work, and I am very happy to be able to share some of that work here with you today. So what I'm going to talk about is a little bit about So surgery is a complicated process and it's a huge undertaking for nearly all patients that come through our clinic. And it matters how we prepare the patient before they go for the surgery. And so, just no disclosure on my part, and this is what I'm going to talk about really briefly in the next 15 minutes or so. And just a little bit of background, as we all know, aging is one of the major problems that we're going to face as a public health issue, and all of us know the significance of that. There is a lot of focus on it on the international level, and you can see that even at the WHO, so the World Health Organization level, there's also a lot of focus on it, and a lot of reports are coming out in how to deal with it as a global entity. Here we can see that as people age, as the world population ages, there will be more and more people with cancer, unfortunately, because cancer tends to occur in the old, and if there are more and more old people around, the incidence of cancer would therefore increase. And we are seeing it now in our clinics as we deal with more and more people who are getting older in age. And so here I want to introduce a concept called ERAS, so ERAS, and it actually stands for Enhanced Recovery After Surgery. This doesn't just apply to cancer patients, it doesn't just apply to older people, but to anybody who goes through surgery. And a lot of people thought about the whole process of going through surgery, and the start of this was when surgeons looked at how patients recover before and after surgery, and they decided that, hey, maybe it's not just doing the surgery and making sure we do a good surgery. While that is an important component, perhaps there are other aspects of surgery that can help in the recovery of a patient. And so this concept came about because of this, as a holistic approach to try to get patients through surgery and let them recover even faster so that they can go home and be with their loved one, etc. And essentially, it is a standardized way of dealing with standard operations, looking at various little things that add up to a healthy recovery after an operation. Okay, so that's the concept of ERAS. And I mentioned that because in pancreatic surgery in particular, pancreas cancer is challenging to deal with as in itself. And to be able to do a good surgery not just requires a lot of effort on the part of the surgeons, but actually also requires a lot of effort on a lot of our other colleagues, our healthcare colleagues, like the physiotherapists, the pharmacologists, the anesthetists, etc. And so this concept anchors a protocolized pathway to make sure that everybody's on the same page, that everybody knows that, hey, we're dealing with a patient with pancreas cancer. This is the surgery that the patient has gone through. This is what we need to do. And it has been shown through research that by doing this would actually allow our patients to actually get through the whole surgical stage faster and recover faster so that they can go on to the next therapy. And so this is a combination of some of the research that international giants have done, publishing about the concept of ERAS applied to pancreas surgery. And I won't go through all that in detail, obviously, and you can see that it actually is a combination of, I think, about 314 studies. This was published just a couple of years ago. And here they list, so in that article, they list a certain number of things that needs to be done as part of this pathway. And I'm just going to highlight a few things. One is this concept of prehabilitation that I'm going to touch on next. But the idea is that before the surgery, if we look at a particular patient and we say, hey, this patient, we know that this patient is going to go through surgery, let's give him some time, let's give him or her some time, and we make some effort to build up the reserves of that patient so that they can go through the surgery in a better state. So that's the idea of prehabilitation. Again, I'll touch on a little bit more on it later. But what applies to a lot of our patients is one of this, which is that before the operation, some patients will ask me, hey, what can I do to prepare for the operation? Other than, making sure you're eating well, other than making sure that you continue to do certain exercises, one thing that you can do if you happen to be a smoker, for example, or you happen to drink alcohol regularly, is actually to stop. or to cut down. And that can actually prepare you better or your loved ones better for the surgery ahead. Okay. So there are various recommendations. I think it runs until like 26 or something. And I'm not going to list all of them. But suffice to say that a lot of details are being looked at and various people are involved along this whole pathway. For example, in this case, even the anesthetist is involved, what drugs they have to use, etc. And that can help the patient go through the surgery in a quicker sense. Okay. So after the operation is not done yet, and there's a lot of things that actually, as a patient, or if you are a loved one and you have family members going through surgery, is the homework is not finished yet. So, for example, we can do the perfect surgery, but if after the operation, the patient doesn't have the motivation to recover, then that will be a problem. So it's very important. I always tell my patients after the operation, I always tell my patients' loved ones after the operation that it's very important for you to continue to encourage and motivate the patient after the surgery, because early mobilization, walking, doing breathing exercises, pushing yourself to eat just a little bit more, all these little things can actually help the patient recover faster. So here I'm going to touch a little bit on prehabilitation. This applies a lot to frail patients who tend to be older patients. And as you know already, with an aging population, we have increasing incidence of people who are physically inactive. And you can just see from this chart that across many countries, Singapore is not listed here, but across many countries, this probably runs at 10% and above, people who are physically inactive. And so the concept of prehabilitation came about in order to look at ways to prepare a patient better for a major operation like pancreatic cancer operation. And this can be thought of in 3 different ways. One is physical prehabilitation, 2 is nutritional prehabilitation, and the third area is psychological prehabilitation. And the whole idea, as you can see from this chart on the screen, if you look at the red color chart, without prehabilitation, when the patient is being diagnosed with pancreas cancer, for example, if there's nothing that is being done from the time of diagnosis to the time of operation, it's very easy for the patient to slowly slide downwards in terms of functional status, in terms of muscle bulk, in terms of what they can do on a daily basis. Because it's very easy then to have a little bit of perhaps depression and just to be a little bit withdrawn. And so the idea of prehabilitation is to try to ensure that the patient follow the blue color line as much as possible, so that their functional status, the walking distance, what they can do, the lung capacity, all that is slowly improved from the time of diagnosis to actually the time of operation. And you can see it at the time of operation where it's labeled as surgery, there will be a huge drop in this functional status. There will be a huge drop in the reserve of the patient, because the surgery, even if it's done perfectly, the surgery will still be an insult to the body, and it will take away some reserve from the patient. There will be a huge drop. And the idea of prehabilitation is that if we can increase the functional reserve of the patient from the time of diagnosis to the time of operation, then despite the drop, they will still start at a higher baseline after the operation, and that can help them recover faster. So that's the idea of prehabilitation. And as you can imagine, if it's such an important concept that can contribute to patient recovery, there will be a lot of interest, and certainly there were a lot of articles that has been published all over the years by various people all over the world. And in our own unit, we also undertook a study like this together with Professor Bonnie and Professor Kao. I did a study on this, looking at prehabilitation, and we also found, not surprisingly, that the functional reserve of the patient is indeed increased after such a prehabilitation pathway, and also that after the operation, post-operative complications would actually decrease after patients go through prehabilitation well. And that brings me to the last part of the talk, which is a little bit on our own experience in NUH. So in NUH, we have a program called the MOUSE program. It is a little bit of a mouthful, but it stands for Management and Innovation for Longevity in Elderly Surgical Patients. So it stands for the MOUSE program in NUH. And what it really entails is a combination of various stakeholders that contribute to healthcare and taking care of patients. So the nurses are involved, the anesthesiologists are involved, etc., physiotherapists. And it includes the eras that I talked about earlier. So all the little details that I mentioned earlier is also included in this program, in this pathway. And a simplified version of what our patients go through is summarized in this chart, where essentially when the surgeon, when I see you in the clinic, I don't really want to see you in the clinic, but if I see a patient in the clinic, for example, with pancreas cancer, unfortunately, then and the patient fulfills certain criteria for inclusion into the mouse program, then I will let them go through the pathway where essentially they will see various people, and if they are noted to benefit from some physical prehabilitation, some physical exercises before the operation, then we will send them to the physiotherapist and they will give the requisite advice. Or if we find that they are malnutrition before the operation, then we will send them to the dietitian and the relevant advice will then be given. It is actually a lot more complicated than that slide, and this slide kind of summarizes it a little bit, so you can see that there are a lot of stakeholders involved in our program in NUH. And also we did an audit of our own program when we published a paper on that of our own program. And we actually found that with the mouse program, with prehabilitation and the ERAS component added in, we find that our patients actually can ambulate, can walk faster and earlier after the operation. And at the same time, they can participate in more rigorous exercises as documented by the physiotherapists after they've gone through that program. And also when we analyze some of the subtext and look at some of the figures within that study, interestingly, we find that they were actually able to adhere to some of the chemotherapy recommendations after the operation. Exactly why we're not very sure, and the study is not able to answer that question, but it was an interesting observation nonetheless. And it's also interesting to link it to some of the experiences from other institutions all over the world, where some of them actually found that with prehabilitation, it actually improves survival, or it actually improves the outcome of certain patients with cancer. So that was what we found in our study, that there was an increased patient mobility and that there seems to be an increased adherence to some of the chemotherapeutic recommendations. And I'd like to end with this slide. Although this patient of mine didn't suffer from pancreas cancer, but the concept is the same, where this patient was actually more than 80 years old, and she came to us in the clinic in a wheelchair, and we said, okay, you have cancer, but the cancer actually is resectable. It can be operated on. But the patient was in a wheelchair and she probably wouldn't have been able to go through the surgery well and fit enough. And so we said, okay, why don't you go through this program? You go for prehabilitation. We sent her to our partner hospital, I think it was SLH and St. Luke's Hospital in this case. They did a lot of physical prehabilitation for her, and she was actually able to walk, as opposed to being in a wheelchair. She was actually able to walk after a couple of weeks of prehabilitation. She actually underwent a surgery successfully after that. So that was a very encouraging result. And just to conclude, so there are strategies available to peri-operatively, before the time of surgery, during the surgery and after surgery to actually deal and try to improve the outcome of the surgery. Pancreatic surgery is not something that is easily undertaken, but with a holistic effort, we are hopeful that we can improve our patient's outcome. Thank you very much.
So we'll come to the last talk of this session. It gives me great pleasure to invite my senior consultant colleague, Professor Alfred Kao. He's a well-accomplished surgeon, a well-accomplished academic and scholar as well, and he's going to share with us on surgery of the pancreas.
Thank you, Glenn. Thanks for the invitation, and today I'm going to talk to you about surgery for the pancreas. And a lot of people will worry about when they hear about surgery of the pancreas, because a lot of things that you hear from relatives, friends in our market, when the friend discuss in coffee, say, oh, operation for the pancreas, very scary, like a lot of complications, and so forth. But I'm just going to tell you that there's a lot of advancement in this area. Nowadays, actually, pancreatic surgery is a lot more safer than before. And in fact, many patients who have successfully gone for surgery have done very well after that. The speaker has been standing here addressing this group, so I think you feel a bit ignored. I'm going to stand here, okay? Right, so my name is Alfred. I'm the liver surgeon in NUH, and today I'm just going to share with you what we do for the tumor of the pancreas. In fact, Mr. Tan is one of my long survival from pancreas cancer who is sitting behind. Okay, a lot of words, but essentially I want to tell you that pancreatic surgery is not easy. It's because of the location of where the pancreas is. It's very deep inside the abdomen, and it's surrounded by a lot of important blood vessels and structure. As a result of that, in the old days when surgery were to be done for pancreas, it's complicated, and there's a lot of risk of, in fact, bad outcomes, so on and so forth. But over the years, we have learned to understand this condition, this organ better, at the same time improve on the way how we do the surgery. Also understand when there's a potential complication that occur, what can we do to mitigate the situation and turn a bad situation to be good. Okay? And so I highlighted to you just now, where exactly is the pancreas? A lot of people ask. Dr. Chi mentioned just now, pancreas in China is called the Yizang, or in Hokkien it's called Qiu. It's actually a very, very deep organ right behind the stomach, where it's linked to the bile duct, liver structure, stomach, and small intestine. So it's in a location that's very deep inside and surrounded by a lot of important structures. So to get to it and do the operation is not easy. But nowadays we have ways that we can do it very safely. Also importantly, to know what does the pancreas do. Okay, the pancreas has two major functions. So Dr. Chi mentioned just now earlier about food and things like that, sugary food and things like that. It's because the pancreas does one part is to secrete hormones that regulate our sugars. So when the patient has diabetes, it's because the pancreatic cells are not functioning well enough. At the same time, also it secretes digestive juice that helps us to digest our food. So as a result of that, when we do surgery for the pancreas, we need to take care of what potential problem that can come from these two major functions from the pancreas. Dr. Teng mentioned a little bit about the various indications for pancreatic surgery. Well, most of the time, pancreatic surgery to remove part of the pancreas, the indication is for cancer. I also highlight to you nowadays, more and more patients come with what we call a pre-malignant condition. A lot of patients go for screening for other purposes. One of our most common referral source actually is from urologists. When the patient go for a test of traces of blood in the urine, they go for a scan to see whether there's any stones in the abdomen. But as a result of that, when they screen the area in the urinary tract, actually the pancreas is also within the region. They may then see incidental finding or something abnormal in the pancreas. That's when they refer the patient to see us. And for us, when we detect some of this pre-malignant lesion, we need to know, do we need to deal with it because there's a chance it may become cancer, which is what Dr. Teng alluded to earlier. So what are the key things that we need to know about? On the right-hand side here is confirmed cancer, that if it is possible to do surgery to remove it, and patient is fit, then we should consider surgery to remove it, because if the surgeon tells you it looks like a tumor, yet we can offer you the operation, that's the best option you can have, because systemic therapy, while you can control the disease, cannot remove it completely. So we work closely with our oncologists to offer a potential curative option for our patients. On the other hand, on the left-hand side here, we see actually various kinds of cystic, meaning water bubble that's present inside the pancreas, and some of them may carry the risk of becoming cancer. Okay, so there, for example, keywords that you will hear if the patient happen to have a scan done and then they say they find a cyst, the cyst is connected to the pancreatic duct, then the condition is called IPMN. And when you search on that, basically in simple layman term is that the pancreatic cells have undergone changes such that instead of secreting digestive juice, they start to secrete some kind of a sticky, mucus, starchy-like kind of material, and that's representative of the chance of it becoming malignant. And its location in different parts and involvement of the pancreatic duct translate into different risks of cancer. So nowadays, more and more, we are seeing patients with this kind of condition that may potentially come to us when they say, look, I think it's grown to be a big 3 to 4 centimeter now. Maybe we should consider surgery to remove it to prevent it from progressing to become cancer. Okay, so I have a patient who's exactly like that, where we removed a head of pancreas, very big cyst, about 3 centimeters, 3-4 years ago, and we kept behind the remaining 2/3 of the pancreas, and then last week he just came to me, and another lesion has grown in a tail, and now he needs to have further surgery to remove that, because there is a chance that it can occur again in the remaining pancreas. We also mentioned a little bit about how pancreatic lesions are presenting. So Dr. Teng mentioned that if the lesion's in the head, then obviously we will need to look after the patient in terms of whether there's any signs of jaundice. If your urine turn into like all kind of color, something is wrong. It should be at least clear color, if not chrysanthemum tea, but it become oolong cha means it's very, very dark, and that's something wrong about it. If your motion is supposed to be colored, suddenly it becomes gray color, then you have to be very careful, okay, because that means that the bile duct is blocked and maybe there's a tumor growing there. And more importantly, I want to highlight that tumor in the body and tail, unfortunately, is detected very late because it's in a very deep location, far to the left side, and there are not many structures around there that will allow you to have symptoms. So the patient who presents with body and tail pancreas cancer often a little bit late, but nowadays there are also things that we can do to potentially increase the chance of doing surgery, which I'll show you later. Okay, I want to highlight to you the concept of what we call borderline resectability. Okay, in the old days when we say blood vessels stuck together, maybe not possible. But nowadays there are things that we can do to try to improve the chance of being able to remove the operation. And so this chart essentially shows us where the pancreas is, and there are a lot of important blood vessels that crosses it. And these are blood vessels that are essential for life. Why is that so? It's because the blood vessels supply oxygen to all the intestine and even part of the colon, and then the blood needs to flow back to the liver for it to be processed. And if the tumor is located here, you will wrap around this blood vessel, then the outcomes are not so good because it's a bit more advanced. So it's exactly what the oncologist and the surgeon needs to look at and say, is it possible to remove it? And then if we remove the tumor, would there be benefit for the patient in terms of improving the survival? So that's where we want to understand now, based on the scans, can we see, for example, in this case, a tumor here, how much of it is stuck around the blood vessel, and vein versus artery has slightly different outcomes. And therefore, as a surgeon, at the end of it, when we assess and we say, okay, it looks like it's a bit more locally advanced, and maybe we'll send you to the oncologist for some chemotherapy first. If there's good response, then we will consider surgery. Okay, and this essentially some medical terms to really show you very good ones, like Dr. Teng showed you, very early T1 stage means the vessel is not involved, versus tumor there's a bit wrapping around down the vessel versus completely encasement, and therefore maybe not so good to remove the tumor at that time. Okay, this just showing you again a few possibilities of where the tumor may be growing and then wrapping around the vessel. As a result of that, we may need to do more to do the chance of increasing our chance to resect the tumor. And more importantly, I also want to highlight that nowadays, because our surgical technique has improved, we can even, in good situation, remove part of the vessel and join back and give the patient the chance to go for an operation and remove it completely. Okay? Now, surgical treatment of pancreatic lesion, I will highlight first part first. This is for cystic lesion. So for some patients who might have cysts in the pancreas and they are not confirmed cancerous yet, like I mentioned, maybe the IPMN or the mucinous type of tumors, some may be observed, but when it reaches a certain threshold, we will consider surgery. Surgery in this case often need to balance the risk of it becoming cancer versus the risk of the operation. In other words, when a surgeon offers the patient surgery, it's because we think that time is right now, the risk of you accepting the risk of operation is lower because the benefit is higher, because when you remove this lesion, there's no chance of it becoming cancer, right? So that's what we are doing, and essentially, that's what the surgeon and the whole medical team needs to have a conversation with the patient. It's time now. I think the benefit of doing the operation is better compared to the risk of the operation. If there's no need for surgery, that's best. But when there's a need to, we need to be able to accept that the risk is worth taking, right? That's what we want to do. But at the same time also, if the lesion is located in a body or tail and that, a lot of patients will ask us, oh, you're going to remove the tail of the pancreas, how about the spleen? Because the spleen is right next to the pancreas, and if you need to remove the pancreas, can we spare the spleen? So that's where we will need to discuss. If it hasn't turned into a malignancy, not a cancer yet, sometimes we can help to preserve the spleen. Spleen in this case is 脾脏. I'll show you in the picture later on why we think about that. Also importantly, when it comes to cancer, how do we decide whether it's possible to remove? Is based on this chart here. The further away, the more green it is, more likely that it's less stuck to the vessel, the higher the chance we can remove. But when it starts involving artery and so on and so forth, or even worse still, spread to other parts, then surgery cannot be done. That's really not good news for the patient, because by the time the tumor has spread to somewhere else, it is distant disease, is stage 4. Even when the surgeon says, I really want to help you, but I can't, then that's not a good news for a patient with pancreatic cancer. Okay, of course, Dr. Teng also showed you various kinds of scans that's used. It can be CT scan, MRI, or PET scan that we do to really find out information that can give us an important way to make decision the best for the patient. Also, what we are really looking for is make sure the tumor hasn't spread. Then we want to study closely and see whether the blood vessel has been involved by the tumor. Okay? And as far as pancreatic cancer is concerned, when it's confirmed cancer, then we often want to group them into various stages to decide what kind of treatment there are. So for upfront resectable, Dr. Teng shared with you some of those, and we'll share with you some of the key strategies. I mentioned a little bit about borderline. That means those may be better to have a bit of chemo, or those with locally advanced disease. And nowadays, there's a lot of advances here, and in NCIS, we work very closely with our oncologists, especially even for elderly patients. We have a golden program, which is where Miles is working closely with the oncologist to make sure that if the patient who is old, going for chemo, how do we improve the fitness of the patient to complete the chemo so that they can go for surgery and do well after that. It is a 一条龙服务, one streamlined process where we get all these processes in place so that even the oldest patient that we have can go for surgery successfully. We do not want to deny old people the chance to have a curative treatment just because they are old. A lot of our patients come with their children and say, oh, she's 65. Quite old already, they can go for up. 67 is not old, you know. Okay? Our oldest patient who have gone through the program is 98 years old. Okay? She has gone for a combined liver and colon operation after gone through the exercise and she's on chemo and so on and so forth. So age is not the limit here. Okay? You should give yourself encouragement to say you want to live healthily, we are able to go through the process. Right. So there's a lot of ways where we can try to improve on the outcomes now. And giving a little bit of chemotherapy before sometimes can improve the ability of us cleaning up the area and then do the surgery better. Okay? At the same time, I've gone through some of this now. So quickly, we're going to talk about the kinds of operation that needs to be done. There are two big groups, or even three. But perhaps the two most common groups are those that involve removing the head of the pancreas, where the tumor located in the head of pancreas over here, then we'll remove the head. But because the head is stuck to the small intestine, the bowel duct, all this needs to be removed. Now, of course, we will use sutures to join that back. Very complicated, right? I said that the organ is so deep inside, remove so many things and we join back so many things. But we can do it quite safely nowadays. The outcome's very good. And I also show you that, like what Dr. Teng mentioned, not only that it's done open now, nowadays it can be done by keyhole surgery. Okay, with very good outcomes. Okay, so that's what we do. Patient may have a few 3 to 4 small holes, and then we can actually remove the tumor safely. For example, in this case, conventionally, big incision in the tummy, nowadays we can do it with just very small keyhole surgery. And I know that this is a talk for laymen, so I won't show you too much blood. I just want to show you some instruments of how we do the keyhole surgery, such that you can actually see that the instruments actually go through a very small part in the abdomen, and then we do the surgery by using very advanced instruments that can help us to seal blood vessels and dissect the organs safely. And then we can even do stitching using sutures and things like that inside this small keyhole as compared to now previously in a very big abdominal operation. Okay? At the same time also, there are more advances in this now. Dr. Chi mentioned about precision medicine, where they use molecular biology and so on and so forth to decide on treatment. In the surgical front, actually, we're also now starting to explore more advanced technology that can help us do the operation more safely. Studying the anatomy of the organ, we reconstructed the pancreas using a hologram and studied the relationship of the tumor to the blood vessel. And potentially, that can be used to guide operation. This is like pilot training, right? They go for simulation. We can do the simulation, imagine how the operation can be done. Also, maybe in the future, this can guide us where you're close to important blood vessel. They give you a signal to say, okay, maybe you want to be a bit more careful and so on and so forth. Really hoping to enhance the safety of the operation. When the tumor is in the body and the tail, I mentioned to you just now about the spleen. And why is it important? It's because if there's a tumor in the body or tail, the spleen is nearby. In order to clear this whole area and clear the cancer and the lymphatics around, the spleen often needs to be removed. Okay, so nowadays, a lot of patients will ask, oh, can I save my spleen? It's not important to think so much about this because we can give vaccination to improve the function of the body, to restore somewhat the immunity of the body. A lot of people are worried that when the spleen is gone, the immunity is going to be affected. In the old days, maybe, because there's no vaccination. But nowadays, with the vaccines that's given, it's very safe, and the risk of getting infection after the spleen is removed together with the tumor is very low. So it's actually relatively safe compared to before. Again, even patients who have keyhole surgery done for tail of pancreas with previous operation done before, all these are now potentially possible. And in addition to that, I think there are also more and more of this operation being done by robotic as well. Okay, so why are we able to do pancreatic surgery safely now? There are a few things. Firstly, it's because we have a lot of very advanced instruments that can help us to do the operation. At the same time, also, we have very good camera system that can now allow us to see things in a very magnified and clear manner. And of course, the surgeons are a lot more comfortable doing keyhole in the last 15, 20 years where our skills are improved and so on and so forth. And I'm just going to show you that actually we've done quite a lot of this operation by keyhole, even complex ones, and the outcomes are very good, okay? And just to end off by showing you a case where I think when you think there's no hope, potentially hope is there, okay? This is a patient who is 54 years old. 3 years ago, in fact, came to us and diagnosed to have a pancreatic tumor, and the blood vessel was wrapping around, the tumor was wrapping around the blood vessel, and up front we said, sorry, I think we cannot offer you operation. So he went for chemotherapy, went for radiotherapy. In fact, we can do very complicated operation at the end of it because after a prolonged period of chemo and radiotherapy, he showed very good response, and the blood vessels at that time now were separated away from the tumor. We then able to do very complex operation. In fact, we had to cut away the important vessels that we say is crucial for life. And at the same time also, then we can join back using special blood vessels to reconstruct. So all these complex things can be done nowadays quite safely. It's because of the understanding, the advances that we have. And ultimately, he has done very well. We are able to get him clear margins. And also the improved safety of the operation. We want to make sure that we've cut away the blood vessel. How about the remaining organ? Is the blood supply good? Nowadays, we can also use additional system, like we inject this very interesting dye that you see the moment we inject it. If the blood flow is good in the organ, we can then see that it will light up in a green light, showing that actually the organ is well perfused. Okay? You can see the blood vessel flowing in with the dye now. So this stomach, we're concerned that the stomach may be not having blood supply and is dangerous. Now the operation has additional tools that can allow us to improve the safety of the operation. Okay, so I want to conclude by saying that actually complex liver surgery, pancreas surgery now is very commonly done. Okay, and as a group of oncologists working with surgeons, we now try our best to work in a very comprehensive manner to deliver the best care for our patients. Pancreatic surgery is not as scary as before nowadays, okay? And more importantly, alluding to what Dr. Pang has mentioned, don't deny the old people the chance of a curative treatment just because you think he or she is old. We are able to now improve on their fitness and then allow them to go for the treatment that they need, and they can live normally and well after that, okay? So with that, I just want to end my talk, and then we'll be happy to take some questions later on. Thank you.